We're going to be talking about wrist flexion and how to measure it with the universal goniometer. So first of all, we're going to talk about a little bit of the biomechanics that are involved in wrist flexion. So wrist flexion involves two joints. We have the radiocarpal joint and the midcarpal joint. The radiocarpal joint is made up of the radius and radial ulnar disc, also called the TFCC, along with the scaphoid, lunate, and triquetrium bones of the proximal carpal row. The midcarpal joint is made up of the scaphoid, lunate, and triquetrium, and the capitate and hamate. Both of these joints are reinforced by various ligaments, namely palmar radiocarpal, ulnar carpal, dorsal radiocarpal, ulnar collateral, and radiocollateral ligaments. And these are continuous with the joint capsule. Lastly, arthrokinematics are involved in wrist flexion. So for the radiocarpal joint, we have the convex proximal row carpals roll ventrally and glide dorsally on the concave radius and radioulnar disc. At the midcarpal joint, there are two different movements that occur. The convex capitate and hamate roll ventrally and glide dorsally on the concave scaphoid, lunate, and triquetrium, while the concave trapezium and trapezoid bones roll and glide ventrally on the convex part of the scaphoid. All right, there are several indications and contraindications for measuring wrist flexion. So if you in terms of indications, if you suspect stiffness in that joint, in the wrist joint, or if you think that that range of motion deficit is going to lead to later disability, you want to measure that. In terms of contraindications, you don't want to measure wrist flexion in your patients if they've had a dislocation in that area, or if they have had an unhealed fracture, if they have osteoporosis, or if they've just had surgery.
So now we're going to talk about how to measure wrist flexion using a goniometer. So in terms of patient and therapist positioning, you're going to have the patient just seated next to a table, and as a therapist you can also be seated for better body mechanics. And you're just going to ask the patient to put their arm up on the table. And what you're looking for here is that the shoulder should be at about 90 degrees of abduction, the elbow should be flexed to about 90 degrees. And you're going to move forward a little bit so the wrist is off the table so you can get through that full range of motion. And as you're aligning the goniometer, what you're looking for here is the axis is going to be on the triquetrium of the wrist, and you're going to align the stationary arm along the lateral midline of the ulna, and you can use the olecranon process as a guide here. So we're going to line up here. And for active range of motion, you're just going to ask the patient to bend their wrist down toward the ground. Make sure they're going as far as they can into that motion. You just bend all the way. Perfect. And we're going to line up the moving arm with the fifth metacarpal, and make sure you're lining it up with the bone and not the hypothenar eminence in the soft tissue there. So lining it up here. Choose at about 70 degrees. Go ahead and relax. And then we're going to do the same thing for passive range of motion, except this time the therapist will push down through the third metacarpal into that end range of motion. Okay. So we're lined up, lateral midline of the ulna, the olecranon process, triquetrium, and then you're just going to press down on the third metacarpal. And in this case, passive range of motion equals active range of motion, which is about 70 degrees. And throughout this, you want to be making sure that the patient's wrist is stabilized between pronation and supination. So if you need to, you can stabilize with the radius and the ulna.
Average wrist flexion is generally between 60 to 80 degrees. Active range of motion for wrist flexion is assisted by the flexor carpi ulnaris, flexor carpi radialis, flexor digitorum superficialis, and flexor digitorum fundus. Range of motion can be limited by tightness in the extensor compartment, as well as weakness of the muscles listed above. Test psychometrics for wrist flexion. Intra-tester reliability was found to be greater than inter-tester reliability. Validity for this measurement was only studied in groups with disability or impairments. It is also significant that improvements in wrist flexion were not found to have a significant effect on return to functional tasks.